disasters, Tip of the Iceberg, an international webinar conducted by the International Pediatric Association, uniting thousands of registrants from all over the world. This webinar discusses important issues to hopefully shed light on the physical and mental health problems in children exposed to natural disasters and how we can better support children and families at such circumstances. Before beginning today's webinar, we would like to inform you of the rundown of this webinar. Okay, we will begin with a welcoming address from the Executive Director of the International Pediatric Association, followed by our honorable keynote speaker. Then we will have the presentations from our distinguished panel of experts moderated by our esteemed moderators. There will be a Q&A session with our speakers. For the smooth running of today's event, kindly pay attention to the following rules and regulations. First, participants are encouraged to have their videos turned on throughout the webinar. Second, participants should keep their microphones off unless permitted by the moderators. And then the last one, to obtain the certificate of attendance, participants are required to attend the entire duration of the webinar and fill in the feedback form, which will be distributed at the end of the event. I will now invite our honorable first speaker to deliver the opening remarks. Professor Ahmad Bakti Pulungan, MD, PhD, FAAP, FRCPI Honors, is the Executive Director of the International Pediatric Association and also the former President of Asia Pacific Pediatric Association, Indonesian Pediatric Society, and the Asia Pacific Pediatric Endocrine Society. He is also a professor in pediatrics at the Department of Child Health, Faculty of Medicine, University of Indonesia, Cipto Mangunkusumo Hospital. For the past 20 years, he has been involved in many programs for diabetes and child health in Indonesia and across the globe. He has been awarded by the Indonesian Ministry of Health as one of the most eminent persons who has been actively involved in the national immunization program. Recently, he has also been received the Republica.co.id Inspirational Figure Award 2021 for his work in children's health during the COVID-19 pandemic. Without further ado, to the professor who needs no introduction, to Professor Pulungan, the time and screen is yours.
Good morning, good afternoon, and good evening. Today, on behalf of the International Pediatric Association, I would like to welcome you to the physical and mental health problem in the children exposed to natural disaster, Tip of the Iceberg webinar, organized by the IPA Strategic Advisory Group on Children in Humanitarian Emergencies. Moreover, we would like to extend our gratitude to Mr. Budi Gunadi Sadikin, Minister of Health of the Republic of Indonesia, leader of the G20 Health Working Group, for taking his time to deliver the keynote speech in this webinar. The threat of natural disaster caused by climate change is as significant as the COVID-19 pandemic. Climate change is affecting nature and people's life, including children and adolescents everywhere. The World Meteorological Organization, WMO, stated that a disaster related to water hazard, weather, or climate occurs every day on average over the past 50 years, causing more than 115 deaths daily. The dangerous and pervasive impact of climate change are increasingly evidenced in every region of our world, causing natural disasters to occur more frequently. These impacts are hindering efforts to meet basic human needs, and they threaten sustainable developmental across the globe, especially in the aspect of physical and mental health of every child, every age, everywhere. Therefore, we all need to take our part in reducing climate change and educate our community, children, and ourselves to be advocate of climate action. Moreover, it is also important for us, especially as pediatricians, to be prepared in helping children physically or mentally affected by natural disaster. Finally, I would like to honorably thank to Dr. Yogi Prawira and Dr. Denise Bothe, who have taken their time to share their knowledge. Hence, we could be more aware and prepared for this issue. Furthermore, I would like to thank Dr. Abdulsalam, Abu-Libdeh, and Dr. Rinda Arnold as moderator of this webinar. Thank you as well to all participants for attending the webinar. I hope that the participant will be enriched with the knowledge and understanding of problems derived from national disaster and move forward in taking part to ensure that the highest standard for every child, every age, everywhere. Thank you.
Thank you, Professor Pulungan, for your opening remarks. We will now proceed to the next agenda of the webinar. Today, we are honored to have the next speaker deliver the keynote speech, Mr. Budi Gunadi Sadikin, Minister of Health, Republic of Indonesia. Without further ado, we respectfully invite him to give the keynote speech. To Mr. Budi Gunadi Sadikin, the time and screen is yours.
Distinguished colleagues, ladies and gentlemen, children are disproportionately impacted by natural disasters, not only injuries and death, but children are more vulnerable to malnutrition due to the disruptions in food supply and infectious diseases caused by poor hygiene and sanitation during crisis. Furthermore, the crisis often displaces children from their homes, separate them from family, and force them to live in an inadequate child-friendly shelters and also disrupt their education. This situation harm their psychological condition that is aggravated by the disruptions of essential health services, leading to the development of mental health problems in many victims. This situation must change. We have to better prevent, prepare, and respond to natural disasters and other health crises, and to mitigate further adverse health impacts on our children and our future generations. Ladies and gentlemen, Indonesia is located on the Pacific Ring of Fire, leading to the constant risk of natural disasters such as earthquakes and volcanic eruptions. The Ministry of Health of Indonesia therefore has implemented health system transformations to strengthen Indonesia's health resilience toward future health emergencies. We have established an integrated and coordinated multi-sectoral health crisis management through its health cluster. Increasing cross-sectoral collaborations is also a pivotal element to improve our health resilience to deal with health crises. Ladies and gentlemen, beyond national effort to strengthen health resilience, Indonesia promotes the global health architecture strengthening through its G20 presidency of 2022 to accelerate global recovery during health crisis. Under the theme of Recover Together, Recover Stronger, we commit to three priorities. First, building global health system resilience by establishing a global mobilization mechanism for financial and essential medical countermeasures and global genomic surveillance. Second, harmonizing global health protocol standards to revive global mobility of people and goods. And third, expanding global manufacturing and research hubs of health products, such as vaccine, therapeutics, and diagnostics, for pandemic prevention, preparedness, and response. The effort we invest into global health architecture will speed up global recovery during emergency and help make a global system more inclusive, equitable, and responsive to crisis. thus mitigating the worsening of children's health and well-being and promoting healthy development among children exposed to natural disasters. Ladies and gentlemen, I believe each of us has our role to put the foundation, erect the pillars, build the walls and roofs to prepare for future health crises and build a more robust health architecture. We therefore invite all of you to join our commitment and forces to create a better protections and environment for our children who have been victims of disasters. Thank you.
Thank you, Mr. Budi and Sadikin, for your inspiring reminder to us all. The next agenda of our webinar will be moderated by two very special and distinguished guests. It is my great honor today to introduce our moderators for the session. For the first moderator is Dr. Linda Arnold. Dr. Linda Arnold is an associate professor of pediatrics and emergency medicine at Yale School of Medicine, and attending physician in the Pediatric Emergency Department of Yale New Haven Children's Hospital. As former Peace Corps volunteer, Dr. Arnold has been actively engaged in global health throughout her career. At Yale, she was the founding director of the Pediatric Resident Global Health Track and served as Yale Pediatric Lead for Rwanda's Human Resources for Health program from its inception. Dr. Arnold is a faculty affiliate of the Yale Institute for Global Health and collaborating faculty at the Yale Global Health for Leadership Institute. Dr. Arnold has held multiple leadership positions within the AAP, including 2 terms as chair of the AAP section on the International Child Health. She also served on the AAP Global Immunization Advocacy Project Advisory Committee, the International Subcommittee for the AAP Disaster Preparedness Advisory Committee, and as a representative for the Survive and Thrive Global Development Alliance. Dr. Arnold also has been invited to speak both nationally and internationally about a wide variety of global health topics, including the importance of incorporating children's specific needs into disaster planning and response efforts. After serving 2 terms as North American representative to the IPA Standing Committee, she was elected as IPA Coordinator of Development in 2021. She's also the founding director for IPA Lead Child Health Emerging Leaders Program. Good morning, Dr. Linda Arnold. Thank you for your time of being with us today. And then for the next moderator is Dr. Abdulsalam Abu-Libdeh. Dr. Abdulsalam Abu-Libdeh is a consultant pediatrician and pediatric endocrinologist at Hadassah University Medical Center and at Makassed Hospital, who has been involved in both clinical work and research. As a clinician, he takes care of endocrine and diabetic patients at Mount Scopus Endocrinology Unit at Hadassah University Hospital and Makassed Islamic Hospital, covering clinics, diabetes unit, and endocrine consultation in addition to manage diabetic ketoacidosis patients at pediatric ICU during their hospitalization. Dr. Abu-Libdeh is also the co-chair of the IPA Strategic Advisory Group of Children in Humanitarian Emergencies. Thank you. You may take the lead from now, Dr. Abdulsalam.
Thank you very much. I would like to thank you all for sharing us and accepting our invitation to share this important webinar for the benefit of our children all over the world. So I would like also to thank my colleague as the co-chair of the Strategic Advisory Group in the International Pediatric Association, Dr. Özlem Teksam, who is joining me, and she had done a great job in organizing this webinar. So it is my pleasure now to introduce the first speaker to you, Dr. Yogi Prawira. So Dr. Yogi Prawira is a pediatric intensivist consultant that currently works as an academic staff and head of Pediatric Emergency and Critical Care Division, Child Health Department, Cipto, Mangunkusumo Hospital, Faculty of Medicine, Universitas Indonesia, Jakarta. He is a member of Cipto Mangunkusumo Hospital Pediatric Liver Transplant Team, which is considered as one of the pioneers of pediatric solid organ transplant in Indonesia. He also works closely with the Integrated Cardiac Center team, especially in the perioperative management of pediatric cardiac surgery. He has received a number of awards for his research and publication, including Inspirational Youth Award, International Journal Published Research Award from Indonesian Pediatric Society, and International Publication Award from Center for Research and Integrated Development of Tropical Health and Infectious Disease of Faculty of Medicine, University of Indonesia. He is a former member of Research and Human Resources Development of Indonesian Pediatric Society and now serves as a member of Pediatric Emergency and Intensive Care Task Force, the Indonesian Pediatric Society. So thank you, Dr. Yogi Prawira, for joining us. And I will continue. He has joined several voluntary works in disasters and remote areas in Indonesia, such as Indonesian Pediatric Society Medical Emergency Team and Palu Donggala Earthquake and Tsunami, Central Sulawesi, Indonesia, Indonesian Pediatric Society Medical Emergency Team for Lombok Earthquake and Bima Flash Flood, West Nusa Tenggara, Indonesia, also University of Indonesia Medical Emergency Team for Padang Pariaman Earthquake, West Samorata in Indonesia. He is actively involved in the various CME in and outside hospital and his teaching activities involving teaching pediatric intensivists, fellowship trainees, pediatric residents, junior doctors, medical students, and nurses. In addition, he is also a certified advanced pediatric resuscitation course provider and regulatory trains other healthcare specialists in Indonesia. During the pandemic, he serves as the chief of Indonesian Pediatric Society COVID-19 Task Force. Dr. Yagi, the floor is yours now. Thank you for accepting to join us. Please, you can start. Thank you.
Thank you very much, Dr. Abdulsalam, for your kind introduction. Please allow me to share my screen. Okay, can you see my slide?
Yes.
Thank you. Assalamualaikum, a very good morning, afternoon, and evening. It is really an honor for me to deliver my presentation about when disaster strikes, expecting the unexpected. Kindly noted that I'm not an expert in disaster medicine. I'm only a pediatrician that sometimes I work as a volunteer during the disaster. Okay, this is my country, my beautiful Indonesia. Indonesia is an archipelago state with more than 17,000 islands, which lies between Pacific Ocean and Indian Ocean, at the meeting point of 4 tectonic plates, as well as the Ring of Fire. Needless to say, we have a high risk of earthquake, volcano eruption, flood, and landslide. On top of that, we are the 4th most populous country in the world, with more than 270 million people. We can conclude that Indonesia is the big laboratory of disaster. When disaster strikes, the victim load rise beyond local capacity. Main facilities such as road, government building, health center, schools were destroyed. Death toll increases as well as the injured. Disaster impact not only structural destruction, but also poverty, social deterioration, national defense weakness, internally displaced people, and refugees. Children have been disproportionately and increasingly affected by the impact of disaster. No specific data about child victims were stated. However, global data estimated 50% of all the victims were children. The promotion of children's rights must take account of their specific vulnerabilities and risk. Children tend to absorb more harmful substances in the air. They spend more time outdoors even in the disaster situation. Once get sick, children require certain medication, vaccines, special medical equipment. And yet, at certain age, they are unable to express their feelings. Children also have a different anatomy than adults. They have a larger head portion, pliable skeleton, so they are relatively prone to have a head injury. Physiologically, children are prone to have dehydration and shock. They also have a higher respiratory rate if we compare to adults, so they can expose a greater dose of inhalant agents. Children are particularly vulnerable because of the developmental limitations. Infant, toddlers, and young children do not have the motor skills to escape from the site of events, and they have high dependency to adults. Moreover, children may actually migrate toward the event due to their curiosity. This makes children victims have specific needs that require additional care from us pediatricians. It is important to note that disaster-related death can happen within weeks up to months after disaster, and it is mostly preventable. In the rescue phase, we usually deal with trauma victims, but after that, we have to be ready for increasing case or outbreak of infectious disease related, such as diarrhea, measles, upper respiratory tract infection, even malaria and dengue. At some point, we might also have to be ready to help baby delivered and provide neonatal care. We also will face some underlying conditions that already existed but then exposed even more during disaster. If we fail to prepare, we might as well prepare to fail. The first response team should have the capability to do rapid assessment. They have to check for the effective health facilities, what are the total numbers and damage severity, what are the medical equipment that are still available and can run well, local medical staff as survivors, safety of the facility and hospital specification. It is also very crucial to have access of food and clean water, as well as electrical supply. The readiness of the medical team during emergency response is urgently needed, including the readiness of pediatricians to serve child victims. Indonesian Pediatric Society has a long history in disaster management response team, especially since activation of Disaster Management Task Force after Aceh tsunami in 2004. So the Disaster Management Task Force has played active role in several times of disaster management in Indonesia. Disaster management is a continuing process which takes place before, during, and after disaster. During mitigations, actions are taken to eliminate the probability of a disaster or reduce the impact of unavoidable disaster. During the preparedness, government and organizations conduct risk assessment to recognize which disasters are most likely to occur and develop emergency response plan. Immediately after a disaster occurs, response phase begins to provide emergency assistance for casualties, reduce the probability of secondary damage, and enhance recovery. And the objective of recovery phase is to support the affected area to return to normal as quickly as possible, and for recovery activities continue until all systems have been returned to normal or better. There is a paradigm shift of disaster management from responsive to risk reduction, from unisectoral approach to multi-sectoral approach or cluster approach, and centralized to decentralized. WHO has adopted this cluster system since 2005, which aims to strengthen coordination by clarifying the division of responsibilities and roles of each organization or institution. Indonesia had implemented multi-sectoral or cluster approach since 2006 during the Jogja earthquake, which later stated in the Director of National Disaster Management Agency decree in 2014. Ministry of Health acts as the coordinator of the National Health Cluster and has tasks in supporting and facilitating local government in carrying out efforts to overcome the health crisis. In carrying out its tasks, Health Cluster will be divided into 9 sub-clusters: health services, infection control, nutrition service, maternal, neonatal, reproductive health, etc. Professionals' health care mainly take a role in health service subcluster, including pediatrician, which is called as emergency medical team. The WHO has classified EMT or emergency medical team based on its capabilities. EMT1 mobile and fixed to serve outpatient cases in areas that are difficult to reach and in refugee camps. EMT2, which is hospital-based, can serve minor and major surgery. EMT3 will provide referral level care. Pediatrician mainly play its role in this specialist cell, which are maternal, child health, infectious disease, and outbreak. The activities of an EMT will process through 7 key stages. And the first EMT during initial phase have tasks to make coordination with chief of on location, health cluster coordinator, and other institutions who provide emergency response. During the intermediate phase, in addition to continue the first EMT task, EMT also have public health responsibility, including conduct training and supervision to local healthcare providers, aware with potential outbreak, and support local health program, infection control, vaccination, breastfeeding promotion, and nutrition. In the final phase, the EMT will assess if the health assistance can be stopped immediately and also assess for long-term need as well. So the next presentation will show the implementation of all this theory. Duly noted that sometimes we have to be flexible and creative in the fields. These are the views from Indonesia. The settlement patterns in Indonesia are usually located on the slopes of mountains or hillsides, or even by the river. So once the disaster strikes, this situation would be very difficult and vulnerable. I will try to bring our memory to September 2016, when a catastrophic flash flood had occurred in Garut, West Java. The settlement along the river were heavily flooded when Cimanuk River floods in the district of Cimacan. Cimanuk River is a catchment area of river exacerbated by illegal logging. During the Garut flash flood, more than 2,500 houses damaged and even hospitals were destroyed by floods. Casualties were rising up with more than 1,000 internally displaced people. Another flash flood occurred on December 2016 in Bima, West Nusa Tenggara. Healthcare services were paralyzed. All the emergency cases were referred to Bima District Hospital. In just a matter of hours, the hospital quickly became overflooded. The EMT from Dompu, the neighborhood district, was the first to respond. EMT2 were deployed from the army. They directly built a field hospital. Then the specialist cells from vertical hospital also deployed, especially dealing with maternal, child health, and nutrition issue. Quite a large number of victims insist to stay near their houses. It will be very difficult for the EMT to monitor and evacuate. Some areas are dangerous and impossible to access. The pediatrician from Indonesian Pediatric Society Disaster Task Force were aware about a cluster of acute viral exanthem in the refugee camp. We then decided to collaborate with other institutions to do an active case findings. The team were deployed to houses and camps that are scattered all over the district. We report the data collected to the Health Cluster Organizing Committee and advocate the need to do an urgent response to the mayor office. We have difficulties in terms of convincing the authorities to acknowledge the critical situation we are facing. Measles is highly contagious. If we didn't act rapidly, we will be dealing with a measles outbreak. Patients will be overflowing the hospital, not to mention the post-infectious complications such as encephalitis and pneumonia. The authority wants to confirm the measles serology by sending the sample to Surabaya. It will take days to have the final results. So me and my fellow pediatrician, we insist that measles is a clinical diagnosis. From the active case findings, we have found children with the rest phase and hyperpigmentation during the recovery phase. So we must act now or it will be too late. After coordination with Prof. Aman, the former head of Indonesian Pediatric Society, and also the head of West Nusa Tenggara Province Healthcare Services, who happened to be a pediatrician, Dr. Nur Handini, we decided to do an outbreak response of immunization. 1,000 of measles vaccine were deployed from the capital, Mataram. We collaborate with the local ulama, local healthcare providers, and Indonesian Army, because we are going to vaccinate some villages that are already notorious as a hardline anti-vaccine communities. Alhamdulillah, we managed to complete it, the mass vaccination within days. So what are the lessons learned from all this disaster? First is the settlement relocation and regulation to prevent illegal logging, and also appropriate building construction. Children as a prone population need special attention, and in emergency setting, clinical expertise and strong leadership are highly appreciated. We also need to advocate for disaster management training for preparedness. On September 28, 2018, a massive disaster struck Palu, Sigi, and Donggala, Central Sulawesi, a 7.4 Richter scale earthquake followed by tsunami and liquefaction. There were mass and scattered victims, more than 2,000 casualties, more than 1,300 missing, 4,600 injured, and more than 200,000 internally displaced people. So the AMT deployment started since day one from the neighborhood district as well as from the ocean. In total, Indonesian Pediatric Society sent 6 teams consists of 12 pediatricians and 3 subspecialties for almost 1.5 month period. We join the daily briefing to report what have been done, what need to be done next. Team will carry out their roles in hospital as directed by Chief of Health Cluster and Chief on Location. During disaster, we also perform emergency and life-saving care in resource limiting condition. This is Dr. Kadafi, our Chief of IPS Disaster Management Task Force. Transport out an emergency patient will subject patient to high-risk environment with multiple distraction and limited resources. The expectation versus reality sometimes can be overwhelming. Our goals during transport is to prevent decrement in care, anticipating deterioration of the underlying disease, minimizing the risk of unplanned events while in the route. This is us evacuate a tetanus neonatal baby to a referral hospital. A bit different with normal situation, in disaster setting, we color-coded the patient with green, yellow, red, and black. If the patient is not responsive to the initial life-saving protocols, we will stop. In a very limited resources situation, we have to reserve all the resources to help as many victims as possible. On the right side, these are the mitigating strategies during medical evacuation. In the early days of impact, the situations became chaotic due to massive number of patients while resources were limited. So we designed triage on location, advanced medical posts, and at hospital, and the referral systems. We managed to hospitalize patients in local affected hospital if the building construction is considered safe. However, in some area, due to local hospital had severely damaged, we have to manage patient in field hospital or even outdoor. We manage critically ill patients at high care unit, even with limited facilities. Fortunately, some of our EMT members have specialty in emergency and intensive care. We have many medical volunteers who have subspecialty background as neonatologists. We manage 6 newborn in NICU designed at local hospital or field hospital. Even in disaster situation, we should encourage mother to breastfeed the babies. IPS have recommendation how to continue breastfeeding during disaster. We also set up outpatient clinic in the local hospital as well as in the field hospital. Although as pediatrician, basically we are qualified as EMT specialist cell, in some circumstance, we should support EMT mobile or fixed. During Palu, Sigi, and Donggala disaster, a lot of babies were born in the refugee camp. They did not get the standard neonatal care, including vitamin K. We noted the authorities about the potential of acquired prothrombin complex deficiencies or vitamin K deficiency bleeding. These newborn can be a secondary victims. We then collaborate with local healthcare providers to actively screen the babies in the refugee camp that are scattered. The route sometimes are impossible, but I was once accompanied by a senior pediatric surgeon consultant graduated from UK. So this is me while giving vitamin K. She acts like my assistant. I was joke around and told her, never in my wildest dream I will have a pediatric surgeon consultant as my assistants. She then calmly said, no, Yogi, you are wrong. In the fields, everyone is equal. So this is us conducting several trainings about pediatric emergency, neonatal resuscitation, breastfeeding during disaster, and many topics regarding clinical practices to local health professionals. While performing our tasks as EMTs, we also make coordination and collaboration with health cluster, local authorities, other institutions, NGO, military, and police in order to make integrated health program for disaster children in disaster area. In the future, in line with the new paradigm of disaster management, the Disaster Management Task Force of Indonesian Pediatric Society will build communication and networking with branch IPS through local PIC in order to make decentralization and regionalization in pediatric disaster management. One thing we are still lack is documentation, but we managed to publish several papers and books about our journey and findings. This study about the impact of 2008 earthquakes to pediatric populations conclude that respiratory and gastrointestinal infections both are the highest findings in children post-Lombok earthquake disaster. In Padang Pariaman, we use pediatric symptom checklist and child depression inventory to screen child with mental health issue. So these are our learning curves as a pediatrician and also as a human being. Thank you very much. I would like to dedicate this presentation to my fellow volunteers. Thank you. Back to you, Dr. Abdulsalam.
Thank you for your beautiful presentations and to be restricted to the time and having enough. So, and we have always, as you have said, we have to be always when disaster occurs, we have to be ready for expect the unexpected, especially in areas such as in your areas. And I think you are experts in that team, as we have to do more workshops and learn from you how to deal it and have your experience to spread it all over to other pediatric societies through the International Pediatric Association. So I think we will move now. Thank you for keeping on time, and I will hand it over to Dr. Linda Arnold, and after that we will go for the questions and answers.
Thank you,
Dr. Linda.
I would like to thank our first speaker for his excellent presentation, and now have the pleasure of introducing our second speaker, Dr. Denise Bothe, who will be speaking about the topic you just saw on that first slide. Dr. Bothe is a double board certified in pediatrics and developmental behavioral pediatrics. She's an associate professor of pediatrics at Case Western Reserve University and faculty at Rainbow Babies and Children's Hospital in Cleveland for the last 14 years. In developmental and behavioral pediatrics, Dr. Bothe specializes in diagnosing and managing issues in children who've had prenatal substance exposures with drugs and alcohol, adoption-related issues, autism, ADHD, anxiety, and more. She's the Global Child Health Program Director for the Department of Pediatrics at Rainbow. Global health experiences include service in Kenya, Laos, Dominican Republic, and Nicaragua. Her most recent global health venture has been working as a consultant for the Early Childhood Development Intervention Project with the NGO AMOS in Nicaragua. Education and global health has been her main academic focus. Dr. Bothe taught in and directed the Preparation for International Health Service course for many years at Case Western Medical School in Cleveland. She's been faculty with and in more recent years co-director of the Special Needs of Children and Families in Humanitarian Emergencies course at Case Western Reserve University, which was started in 1996 by Dr. Karin Olness and has 31 modules based on all the topics relevant to children exposed to disasters. Most recently, this intensive disasters course has changed names with the focus on caring for children and families in humanitarian emergencies. Her topic for teaching this course is the psychological impact and interventions for children exposed to disasters. She also continues to coordinate global health electives and teach in the global health residency and fellowship training track at Rainbow Babies and Children's Hospital. Thank you, Dr. Bothe. It's a pleasure to have you speak today.
Thank you so much. I'm really honored to be asked to talk today. That first talk was very, very important and interesting. And I'm going to share my screen with my presentation now. Okay. So I want to, my topic today is the mental health needs of children exposed to disasters. And I know that the previous speaker mentioned this, and I believe it's one of the most important things for the future functioning of many of these children. And I put this slide first because I want to remember and remind ourselves that the child is really the center in the community and needs the most support from all of these families and organizations and even the government to make sure that their well-being is maintained so that they can grow up and become the most functional adults in the future. And so my challenge in doing these talks is trying to raise awareness. And I think for all of us as pediatricians and caring for children is to raise awareness that mental health is very important for children. In the initial disaster, physical health is also important. Medical needs are very, very crucial. But as we think about as disasters go on, we want to do our best to prevent post-traumatic stress disorder because with children who grow up having these mental health disorders, they don't function as well in society as adults, and that impacts everything around them. So we need to spread the word and more widespread recognition and start to integrate more mental health prevention strategies into disaster planning. I put this slide in to just show, many of us have heard maybe of adverse child experiences is the common term now used, or ACEs in the United States for children who've had trauma and the lifelong effects on physical health and mental health that can occur over the life of a child who has experienced significant trauma. So here's just a long list of potential outcomes that have been researched so far. So the previous speaker mentioned, pre-disaster plan, the different phases of the disaster, and I'm going to talk a bit about things to think about with mental health during these different phases of disaster. And pre-disaster planning is very important for reasons such as it helps to provide a rapid response after disaster to reduce physical danger and mental health issues. And people who have rehearsed or practiced things like these children in this picture ahead of time maybe have an idea. It might reduce anxiety because they have an idea, they have more control over these situations. They know what to do. When thinking of the time period right after a disaster, we know that there's an increase in morbidity and mortality, as was just described, and a lot of injuries, disabilities, and trauma. Malnutrition is a big problem already in many countries. And when there's disaster on top of that, malnutrition becomes a huge need in the community. And children who experience malnutrition will also sustain some cognitive or developmental impact just from malnutrition alone. So that's one thing to think about ahead of time, how to quickly implement access to food in disaster situations or in refugee camps. And poor sanitation also leads to infectious diseases, poor water supply, medical resources. But during this time, research has shown that there are increased rates of additional trauma, child abuse, human trafficking, exploitation, and also intimate partner violence with adults. During the time after disaster is not only physical injury, but loss of family and loss of social structure really impacts the functioning surrounding the needs of a child. And parents are often focused on their own survival and their own experience of trauma. And that can make it hard to help their own children sometimes. And I will talk more about that. So when does trauma become too much and cause some psychological impact? And as with disasters, an event is sudden, unusual, or unexpected. If it disrupts the usual frame of reference with respect to family and the environment, and when it overwhelms a child's perceived ability to cope and be in control. And I don't think it's only with children, I think it's with parents as well that they feel these effects. I just want to mention the COVID pandemic, which is pervasive in the entire world. And I don't have time to talk a lot about it, but these are some of the studies that are showing the impacts on children. I think we've all probably seen with our patients and our families the impact on mental health with the pandemic. And it wasn't such a sudden, it seemed a little bit sudden, but it was sort of not in one day. It was a gradual awareness that, wow, this is a big humanitarian crisis around the world. So what they found is progress has regressed across every key measure of childhood. For example, poverty is a big one. They estimate 142 million more poor households than previously. And education, which I'll mention again later, is very important for children for many different reasons, including as a way out of poverty, but also as maintaining their mental health. And in 2020, they found that so many schools closed that more than 168 million school children were affected. And at least 1 in 3 school children were unable to access remote learning. I know here in the United States, they tried to get every child a tablet so they could learn and log in for their classroom. But even here, it was difficult for many children to access that because you need Wi-Fi, and it was difficult. And I know with my patients here, I'm a developmental pediatrician, and I see a lot of the children who already have developmental and mental health problems. But many children lost months to up to a year, like this study showed in South Africa, of education time, and are significantly behind now academically. So most children and adolescents are resilient, however, and normal functioning can be regained once basic survival needs are met, if safety and security are reestablished after a disaster, and if their developmental opportunities are restored. Here's some studies that have shown the risk and resilience factors with children. Risk factors include if they already have, and this is true for adults as well, if they have a pre-existing mental health problem, they're more at risk, obviously. Children with a temperament or personality that's very shy or slow to warm up or emotionally reactive are higher risk. If parents are not well adapted or not coping well, children are more at risk. And social isolation, they're more at risk. And I think with the COVID pandemic crisis, social isolation became a very big factor from what I see from my family and my patients, causing increase in mental health problems. And I think the title of this tip of the iceberg talk, we are only seeing the tip of the iceberg of the long-term mental health right now from that alone. So, but there are resilient factors. We all know people who and families who just do better in crisis, and higher education, higher intelligence level has been shown to be a factor. Good physical health, having a belief system such as a religion, religious community is helpful, and a supportive social community with close family, friends, or organizations you're involved with. So increased risk factors include increased exposure to the event. If you have a major life event, such a loss of home or loss of a family member, you're higher risk. Separation is big, and I will mention this again later because I think it's extremely important that we never separate children when possible, and if they are separated, get them back to their caregivers. If you felt your own lives were in danger, and if you've had delayed evacuation, people who have initial panic or a higher response, negative response at disaster, they're at higher risk. And increased disaster-related viewing on media. I had to change this. I used to say on television, but now with access to the phones, smartphone, and around the world, more increased access is wonderful, but it also leads to watching sometimes these videos of disaster or images that are very disturbing, and that can increase anxiety. And then, as I mentioned, parent difficulty coping. So I want to mention, because I'm a developmental pediatrician also, that children with disabilities are the most vulnerable. Children are vulnerable, but children with disabilities are the most vulnerable because they might have mobility issues. They can't get around as easily, so it's harder to evacuate, for example. Children who are delayed in development or who have autism do not understand changes. And these are big changes that happen in a disaster situation. And so they might already have emotional difficulties and don't understand why things are happening. So, and they also might lose their connection to their medical support system or their medications even, and that makes them more vulnerable. And they're more likely to have their basic survival needs met, they're more likely to be unmet, and they're more likely to miss school. Many of them are not in school in many countries already in a good educational environment because of lack of special needs resources, but it's harder to get them back as well. And they're more likely, studies show, 3 to 4 times more likely to be a victim of violence. So things to consider when planning for psychosocial management of these children in a disaster is the developmental level of a child. And if we have time at the end, I have several slides talking about the different developmental stages and the ways children might react and red flags, things to look at depending on their developmental stage. So that's very important, I think. And children take on the anxiety of adults. So making sure parents and caregivers get care as needed, and to adapt programs for special needs children. And remember that older children and adolescents are at a developmental stage where they want to do more, they want to have more control, and they're a great resource for helping to care for younger children. So right after the disaster, what do children need? Basically, this is a list of things to help identify the risk factors and to provide reassurance for families, and to make sure there's enough security to protect children who are so vulnerable. So medical triage, obviously. Psychological triage, I'm going to talk a little bit more. Some of you may have heard of this concept. And making sure to reunite children with their parents or family members or some sort of caregiver as soon as possible. The longer they are separated, the higher chance of long-term post-traumatic effects. Getting back to routine is very important. Children need more routine, I think, than we all need routine. I think children need it more, and they need to be fed more frequently than adults do, and take naps and things like that. And explaining to children what happened is important, but not always showing them what's going on the phone, because they don't understand that in the news what's going on. You have to explain to them at an age or developmentally appropriate level, and also mention that people are doing things to help you. It's okay. We're going to do the best that we can to get through this. Providing basic needs and psychological first aid, I am going to mention. I have a slide on that later. As providers, here's a list of some things related to some of the things I've already talked about that you can tell parents or caregivers to help reduce the risk of mental health in a disaster situation. So maintaining routines, as I mentioned, I think is one of the most important things, along with avoiding separation from caregivers. So children need this, and school routines are such a part of our children's lives when they are school age. So getting back to that when things are safe is important. And remembering that children need to play. Adults can go through the day and do this and all that, but children are much happier, and you can prevent mental health if you allow them time to play with some fun activities. And I've seen pictures of children in refugee camps who look so happy because they're playing, even though inside there's a lot of fear going on. But it's a great tool. When parents should be advised to demonstrate coping skills and model them, to be a good example for their children, and to get help when they need it, and to reassure parents and children that strong feelings are normal in this time. It's okay to be upset. It's okay to cry. It's okay to feel scared. But this is what you can do to help be strong to get through it. You give them strategies. And again, protect from re-exposure and reminders. Protect children, especially from images, very disturbing images in the media. For example, if they see some young children, if they see one image over and over again, I will use the example way back. I was an early pediatrician in when 9/11 happened, and children were watching the airplanes fly into the buildings, the World Trade Center, over and over again. They thought it was happening over and over and over again. They didn't realize it was just one time. And that might happen as well with other images. And then look for triggers of behavior problems. And I will talk more about this. So here's triaging for mental health in children. There are different methods. One is using a symptom approach. And so looking at the symptoms a child is having red flags would include disorganized behavior or dysregulated behavior. If a child looks very scared, of course, if they regress in their developmental skills, that is a signal that they are under a lot of stress. For example, if they were toilet trained and they are no longer toilet trained, or if they had good control, but all of a sudden they have a lot of behavior tantrums, that can be a sign of regression. And then very hyperactive or disruptive behavior, unable to control themselves. Also, if they are very quiet or look like they are in shock with a blank stare, which might be normal initially, we all feel that way at first with a trauma, but that can be a shock if that a red flag if that does not improve. I want to mention SciStart is this psychological simple triage and rapid treatment. START with simple triage rapid treatment is something used by emergency medicine, as many of you know, but SciStart is psychological. Some of you may have seen it. It has been around for a while now in the United States. It was founded and created by Dr. Merritt Schreiber. And it's a really great tool and been shown to be a quick way to identify children who have been exposed to too much that may cause trauma. And so traumatic reactions. It more looks at what happens to the person, not their symptoms. But here is a list on this example triage card of, did I see another person die or seriously injured? Did I feel a direct threat to my life? And they can answer yes or no for these, or parent would answer for their child. If they had their own physical injury, or if they lost a parent. So there's this, and if you have like more than 2 of these, you will be more at high risk of having post-traumatic symptoms. So they call it like a dose of exposure. How much exposure has a child had? And then you can use a process like this, where there's high risk, moderate, and low risk using the SciStart method. And a high risk would be a child who is exhibiting symptoms where they maybe feel a danger to themselves or others, or extreme post-traumatic symptoms of anxiety, panic. And these would be children who would need to go into individual counseling very quickly, some kind of crisis intervention management team. At the very bottom that says TFCBT, that stands for Trauma Focused Cognitive Behavioral Therapy. And I will have a slide later that describes that. There is an online program for helping train for that. Moderate risk might be children with 1 or 2 symptoms, risk factors, and then they could maybe be filtered into a program that could help, that works with as a group, maybe in a school setting, or a community group where they work with a bunch of children at once rather than one-on-one. And that's one way to reach more children, to provide some sort of intervention and continuing screening for any high-risk symptoms. In a low-risk group of kids, they're okay to talk with their parents about strategies and work with them at home on coping skills. So I like this method of identifying children quickly for mental health needs, because prevention of post-traumatic symptoms is so important, as I said earlier, for eventual long-term functioning. Psychological first aid is another thing that has been created with several of the traumatic network systems in the United States. Some of you may have heard of this already, but they also have an online resource to help understand how to use this. But it talks about some of these basic things that I've just mentioned earlier in this talk, how important it is to provide safety and helping survivors to meet their needs, and information about how to learn coping strategies and things like that, and then how to connect with the community. There's 8 core actions, and they have a free PDF online that has a lot more detail about these. I put all the words on here because I don't have time to read them all right now, but or to talk in detail about them, but there's a lot available free online to understand this. And this would be something done right away after disaster and ongoing. Same with psychological triage. You don't do it just in the beginning, you re-triage over and over in 2 weeks, in 1 month, in 3 months, in 6 months. And schools can get involved with helping with some of this as well. Trauma-focused CBT is a really helpful resource as well for therapists and counselors. And they have a free I think it's free. Anyway, they have an online training to learn the modules to understand how to help in more detail with some of the specific things for a child who's experiencing a lot of anxiety or trauma-related stress. And then just to, I'm near the end here. I hope I'm not going over my time, but there are several tools available also to help children learn to express themselves. Art and drawing is great, and I really like this. These images were provided by a Thai doctor who has spoken with our course, and a sort of a Likert scale, a way for children to identify how they feel and draw a picture about that. And this was a child who'd received some intervention and then felt happier. Psychosocial backpacks, I think many people have heard of now. They've been implemented around the world, and a lot of times people donate these, but in this backpack allows for tools for a child to process some of the trauma they've experienced and do some things to help feel better. So there's puppets and drawing supplies, art supplies, and maybe a journaling book, ways to express themselves. And then comfort kits are something created by Dr. Timothy Culbert here, and it's, you can buy them, but I think they online, and it's on the IPA website. There's a free document of how to create your own with limited resources, which is usually the case after a disaster setting, but just some stress tools, like the mini squeeze ball here is just like a ball to squeeze to get out stress, but puppets and little toys and things to help. And I also, yes.
Oh, are we near the end? How many slides do you have left? We're into questions.
Two more slides. That's all. This just very quick. Yeah, very quick. I think teaching coping strategies is very important, and I've learned in a little bit of my career how helpful it is to learn some of these self-regulation strategies in terms of learning a skill that you will not forget. You remember when you learn how to do the deep breaths or use positive imagery. And then recovery phase later on, when children get back to school, schools are a wonderful location for helping to provide intervention to help as children and reach more children. And then getting back to school is really important. This is a wonderful agencies for helping getting children back and promoting education for children. Oh, I forgot about this one, but I can talk about it after if we need to stop. This is a wonderful, if I have one more minute.
Yeah, perfect. Maybe we'll have time for that in the question period.
Okay.
So
yeah.
Is that reasonable? We'll move on to the Q&A, and then if there's time or if this relates to one of the questions, we can come back. Thank you so much.
Okay, I will stop my share then. And
thanks. So thank you to both of our speakers, and secondly to Dr. Bothe for the important information that she shared. And I think the two speakers together really covered a pretty broad range of things. First, the idea that disasters, while not eminently predictable, we certainly expect that they're going to come. And it's important, as our first speaker said, to be prepared ahead of time to make sure that we advocate for children's needs to be anticipated and responded to. And then there's the response period and then recovery. But given children's specific psychological, physical, and other needs, we really need to advocate for children to be cared for people to anticipate stuff, have the right foods, the right equipment, to think about things like resilience and mental health and routine, as everyone has said. We're going to move on to the QA session for things that people have submitted in the chat. And I'm going to allow my colleague to ask the first question.
Okay, thank you. Thanks for both of the speakers for their marvelous and open brainstorming for other people that they have no experience about disasters to be expected for the unexpected. So I will start by Dr. Yogi Prawira with the first questions. This is from Indonesia, Lydia Umami. How to prevent children from physical and mental problem when exposed to disaster?
Okay, thank you very much, Dr. Abdulsalam. I will try to answer the first questions and leave the mental problem to Dr. Denise. Yeah. So basically, once we already exposed to disasters, the first thing to do for the parents is anticipations before that. Yeah, because when you have prepared for this, yeah, let's say you live like in Indonesia, we have a lot of disasters. Earthquake. Sometimes in some district, earthquake can be very frequently. So we should prepare before the disasters comes. And once you already prepare for that, then you won't be panic, yeah? Because once you panic, you won't be thinking rationally. And then try to make your children feel safe. You remember when you were in an airplane, and if something happened in the airplane, the oxygen mask should be put on the adult first, yeah, before we try to give to the children, to the younger one, because if let's say we give it to the younger ones and then we collapse, he or she cannot be able to help us. That's one thing. So make sure you are prepared, try to be physically and mentally prepared if anything happen, and then try to make your child feel safe. And then the basic needs such as water supply, food supply. There's one thing that was called as 72 hours kit. Yeah. So basically, once the disaster strike, sometimes it even the SAR team, sometimes they can find difficulties to evacuate. So probably it's a good idea to have this 72 hours kit. Basically, you have the basic needs for your whole family for the next 3 days. Yeah, water supply, maybe canned food, but please do not supply for the formula milk. Yeah, the formula milk is a very bad idea in disaster, because if we don't have enough clean water supply and we cannot heat the water, and then we will have diarrhea because of all this. So maybe that's for the first question, Doctor.
Okay, thank you. We'll move back to the questions. Please, list of questions from participants.
And while we're going back to that slide, if I could just piggyback a question onto that. One of the greatest honors for me was to be invited to Indonesia in 2013 to speak about children in disasters. And we found, even though the disasters in the United States, we had a very bad school shooting close to where I live, and the natural disasters in Indonesia were very different, the children's needs remain the same. And one of the questions that was raised by my Indonesian colleagues was, how do we get a seat at the table, right? We're pediatricians. And doctor, at first you said, I'm only a pediatrician. There's no such thing as only a pediatrician, right? We are the advocates for children. We know what they need, but pediatricians aren't always the ones that are involved in doing sort of government or Ministry of Health planning for things or working with health systems. So I'm curious to hear from both of our speakers, if you have any examples or experiences of how to have an impact, or how to get to sit at the table, so to speak, when the planning is happening, to be on committees, to work with the Ministry of Health. If you've had success in that regard, or advice for anyone else who's interested in doing that in their communities.
Yeah. Maybe please allow me to answer the question, Dr. Arnold. Yes. Basically, at one point, sometimes it's a bit difficult to sit at the same table with the authorities and try to make this advocation for the children. But I always believe when there is a will, there is a way. If, let's say, you have this consciousness to be able to give something for the child, especially during the disaster, some of my fellow pediatricians, they don't join the IPS disaster management service, but there's a lot of NGOs out there that already have like a team that will deploy once a disaster strikes, and we can join any of that. Yeah. So once you are already in the fields, and they will see how you work with the children, how you put all your effort for that. Somebody will note it. Yeah, somebody will note it. Somebody will note. And usually in every disaster area, there will be like what do you call that? A meeting point. They will share knowledge and data. Usually it's like twice daily. Please make sure you make your time to go there. Try to share knowledge, and then at one point of time, they will acknowledge your expertise. They will ask for your information, and once you have their I'm sorry for pardon my English. Once they already have trust in you, then you can start. And never forget about the local healthcare providers. Yeah, the local healthcare providers, because the local healthcare providers usually they already have a rapport built before that. So make sure you don't go there and like be bossy, tell everyone to do this and that. Make sure you have a contact with the local healthcare providers, somebody that everyone listen and respects. Then you can start from that. Thank you.
Thank you. So I will go to the next questions for Dr. Yogi. How do we educate people on the importance of natural diseases, disasters, preparedness?
Thank you. So this is a very important topic here. So I think one of the thing that we can do is like today we are opening this webinar to public here. So people know about all of this knowledge about disaster in the world. Yeah, and then because as Dr. Arnold said, yeah, even though disaster in America and disaster in Indonesia, it's like a different kind of setting, but the basic needs, it's the same. So we can learn from each other. And don't forget to use the social media. Usually, you know, in this era, usually people don't really listen or watch the mainstream media, not as before. So social media will be a very effective ways to advocate about the disaster management preparedness. And let's say if you are working and doing like a crowdfunding from the people to be able to fund this disaster response, try to make it transparent. Yeah, try to have like an active progress report, so the people know that their donations are give to the one that is really needed. Thank you.
Thank you, Doctor. And I would add, as a member of the IPA and you're a member of your National Pediatric Society, to remember that there's strength in numbers, and working through our individual and collective pediatric societies, we can have a larger voice and more impact than we might be able to as individuals. I'd like to go to one of the questions for Dr. Bothe. And in the interest of time, I'm kind of looking at things that may have been covered already. I think number 5 sort of gets to a lot of things. And the question is about autism, but I think we can generalize it, right? Children with disabilities may be unaware specifically of the reasons for environmental changes, but they're very sensitive to changes in routine, especially in a disaster situation. And the chaos of that environment, and I think the sort of the stress on their parents also not being available may affect their emotional and mental state. And this question is about whether there are any preventions that can be done for parents or caregivers for children. But I would also say maybe to talk about in the planning phases and other things that can be done in the environment and kind of with families to provide a sense of stability.
Yes, I was trying to answer this question in the chat very briefly, because it is very difficult. These kids who are unaware, and when a big change happens, they don't cope well, even at home when a small change happens. But also, addressing the different developmental stages, I think is important with children. Children with developmental disabilities may be a certain age, but developmentally they're a lot younger. So prevention, it can be hard when thinking about this. I see a lot of children with autism and developmental disorders, and we talk about parents sometimes creating their child's like a little booklet or writing down on some sort of paper about that child. So my child's responses or my child's needs. And so that people might know, like, this child has autism and they are afraid of bugs or something, or things that they like. And then we talk about preparing, 72-hour preparing a kit, so you have important survival needs like food or water available. But for these children, preparing a kit or bag with extra supplies that comfort them, that help them, that would remind them that they have some of the same things with them. For example, a blanket, or it can be such a different variety of things for children with autism. It could be just a wire or a specific toy, but these children are so unique with autism. So writing things down, I think, is helpful now and in disaster, to have a child with disability to write down their special needs, write down what they like, what they are afraid of, so that, and children with autism are very, very black and white in their thinking, very concrete. So remembering that is like, you don't want to make jokes for these children or say things that might make them think something more dangerous is happening. So just, I like that idea of having a little booklet or some paper where you describe, and that can be done ahead of time. And so that, or a little bag with things that child needs, if that makes sense. And of course, like I said in my talk, getting back to routine, never separating unless you have to. Don't separate a parent from their child is extremely important with especially the disabilities, children with disabilities. I think I'm surprised sometimes how many people in the community don't understand how to help children with disabilities, especially the developmental disability and autism. It's if you don't know how to help them, you tend to move away from them, not because they act differently. Children with autism might scream when or yell when they have, and you don't know how to help them. And sometimes they don't want to be touched. So you need to put those things in writing, I think, is probably the best advice I have for that.
Right,
did I answer that question? Okay, yeah.
You did, and you actually brought up an excellent question, which unfortunately will have to be our final question because of time. But it's really important to keep children or to keep families together. But also there's sometimes when children may be separated from their families in a natural disaster, any other situation, in a school shooting, and just wondered if either of you have practical suggestions or experience or advice for both how to keep families together, but if children are separated, how do you track them and make sure they are kept safe until they can be reunited with their caregivers?
Yeah. I think logistically, Dr. Prawira, maybe he's worked more in the refugee camps, but what we teach in the course is there will be many unaccompanied minors in disaster situations. And the reason this disaster course was started initially by Dr. Olness, because she was taking care of in a refugee camp, 10,000 children who had no caregivers, and realized you need to kind of do things. So the logistics, I think, are difficult, but trying to, if you have many unaccompanied children with no parent, to create pods or systems so that there are consistent caregivers. They may not be parents, but consistent caregivers for a group of children. So they get to know them and they have a trust in one or two or three people that they can go to consistently for help, because that will reduce their anxiety. But maybe Dr. Prawira has more to say on this. It's a big question.
Well, also just tracking their identity and keeping track of where they are physically, right? For Dr.
Right.
For other speaker, yeah.
Thank you. That's a very excellent question. Actually, we learned a lot during the tsunami in Aceh, 2004. So back then, a lot of kids were separated from their families and then brought to outside of Aceh province, and they were like we what do you call that, from their root, and it's very sometimes it can be very traumatic for the children. So basically in Indonesia, we usually live in like an extended family. So if, let's say, the child is separated from their parents, at one point of time, there might be an uncle, an auntie, or grandparents that will come to try to find this child. So in the meantime, make sure that these children have enough security for the basic supplies. So it's a good idea to have a special shelter for children separated from adults. Sometimes even we have to differentiate from different age group, but then we need like a dedicated volunteers or social workers that can manage to try to give these basic supplies for these children. But then it's like in this chaotic situation, like acknowledge about the authority about this issue and make sure that the government involved in this kind of situation. So it's not like a one team or one man issue, but it's like on a higher level, how to we can make this separated family can become one again. Thank you.
Thanks for the great speakers, and we have to move again. Thank you, Dr. Linda. To add something, we have to move to certificate awarding session.
Thank you. We extend our warmest round of applause and appreciation to our honorable speakers and, of course, to our moderators for the incredible and eye-opening discussion. As a token of our gratitude, we will now present certificates to our honorable speakers who have contributed greatly to our learning process today. To present the certificate, we now invite Professor Aman Bulungan, the IP Executive Director, Dr. Indah Arnold, Dr. Oslim Teksam, and Dr. Abdulsalam Abu-Libdeh to present the certificate. And then to our speakers, kindly turn your videos on and smile as we spotlight you alongside the certificate. The first one would be Dr. Denise Bothe.
Thank you, Dr. Bothe.
We will take the picture in 3, 2, 1. For the next speaker now. So the next speaker would be Dr. Yogi Prawira. You may stop smile as we take the picture in 3, 2, 1.
Thank you, Yogi.
Thank you.
Thank you, Prof.
Of course, no event is complete without a photo session. We now invite our honorable guests, speakers, and moderators to once again turn your videos on to take a group photo with all the participants. To all participants, kindly turn your videos on. We will take a group photo with all our distinguished speakers and moderators. Let's give a few seconds to wait for everyone to turn their videos on. I will now take the picture in 3, 2, 1. 3, 2, 1. 3, 2, 1. Okay, thank you. Once again, on behalf of the organizing committee, we would like to extend our warmest round of gratitude and appreciation to all our speakers, moderators, and participants to make this webinar a great success. To all participants, kindly fill in the feedback form as detailed on the slides and via the Zoom and YouTube chat. The certificate of attendance will be shared via email upon completion of the feedback form. Furthermore, the International Pediatric Association conducts routine webinars with a wide range of topics concerning child health. To keep you up to date, we urge you to follow IPA on our social media platforms as detailed on the slide. We have several opportunities for you to participate in IPA webinar and activities. First, IPA will be having the IPA Congress next year in 2023. For more details, log on to www.ipa2023congress.org. IPA also provides opportunities for healthcare workers to enroll in the IPA Vaccine Trust course to become a certified vaccine champion. The course is open to all healthcare workers for free. Refer to the post and IPA website for more information. Once again, warmest round of gratitude to all parties who have made this webinar a success. Thank you, and we hope to see you at our next webinar.
Thank you.
Thank you, moderator, MC.
Thank you. Bye. Good night.
Thank you.
Good morning.
Yeah, good morning here. Thank you, everybody.